Welcome back, everybody, to our ongoing virtual webinar on the clinical management of COVID-19. Today, we'll start with the second session. Yesterday, we heard terrific talks on the pathogenesis and basic virology of SARS-CoV-2, on the antiviral treatment of COVID-19, as well as on the use of convalescent plasma and the clinical manifestations of COVID-19. Today's session, which is actually titled Immunoregulatory Interventions, might more aptly be The Body Strikes Back. We're going to hear three terrific talks about the immunopathogenesis of COVID-19, about the use of corticosteroids in the management of COVID-19, and about the use of other anti-inflammatory agents. I'd like to remind everybody to please submit questions through for the live Q&A through the portal, and you can chat and connect with people through the meeting hub as shown on this slide. And in case you require any technical assistance, please click the live support hub and someone will be able to assist you. It's now my great pleasure to introduce our first speaker, my colleague Galit Alter, who is a professor of medicine and a member of the Reagan Institute. And like our second speaker today, Galit is the co-chair of the Harvard University Center for AIDS Research. Galit, of course, is well known for her groundbreaking work in applying systems biology to understanding immune responses to HIV and other viral infections, as well as to tuberculosis, really focusing on cell-mediated mechanisms of antibody effects on infectious pathogens. And like so many of us, she has pivoted adroitly to the study of SARS-CoV-2. And her talk today will be on what causes the cytokine storm in SARS-CoV-2.
Hello, thank you for the invitation to present here today. My name is Galit Alter from the Reagan Institute of MGH, MIT, and Harvard, and I'm here to talk to all of you about what causes the cytokine storm in SARS-CoV-2 infection. Now, over the last few months since the beginning of the pandemic, we have come to appreciate that SARS-CoV-2 infection can really be divided up into two phases of the response to the virus. The initial response is really a host immune response to the pathogen itself. This is characterized by high temperatures, individuals who have severe manifestations of the disease, as well as dry cough, diarrhea, as well as headache. But this antiviral immune response rapidly evolves into a host inflammatory response phase, really in those who develop these severe manifestations of the infection. And these then are characterized by inflammation in the lungs, shortness of breath, hypoxia, abnormal chest imaging that can then transition into ARDS, shock, and cardiac failure. Now, what is important and what we've come to appreciate is that, serologically, we can already begin to pick up markers as we transition from this viral response phase to the host inflammatory phase by measuring particular bioanalytes like CRP, LDH, IL-6, D-dimers, ferritin, and procalcitonin. They really mark this tremendous inflammatory response. Now, unfortunately, these molecules come up as this disease progresses and does not seem to give us the prognostic activity that we would like to understand exactly what is going on in individuals who end up taking on this more pathological clinical trajectory. But in our efforts to try to understand these serological markers and understand what's happening as we transition from this viral response to this host inflammatory, highly destructive pathological response, what we've come to appreciate is that it's not just these bioanalytes that are popping up in individuals that develop severe disease, but rather what we see in COVID-19 infection is this incredible cytokine storm that emerges selectively in individuals who end up with this disease severity trajectory. And what we begin to see very interestingly is in these individuals on the bottom that develop this severe manifestation of the infection, these individuals start to generate very high levels of IL-1, IL-6, IL-18, and many other inflammatory markers that are really critical in driving this incredible inflammatory response, and ultimately, we believe, to the recruitment of immune cells that then drive the ARDS phenotype that we see histopathologically in the lungs. Now, another observation that has been made as we have really dug deeper into these cytokine inflammatory profiles that appear selectively in SARS-CoV-2 infection, particularly in those that develop severe disease, is really that there are differences across the genders, where we have seen clinically that elderly men tend to do worse with the infection than, for example, women. Now, in a particular seminal study by Akiko Iwasaki at Yale University, what she showed really elegantly is that men and women do, in fact, generate different flavors of immune responses, and particularly differences in their cytokine profiles. Now, just showing you over here on the right side are some of the data here where viral loads in the men in the yellow or the women in the purple were really no different in the swabs, the NP swabs, or in saliva. But interestingly, women here in the purple generate higher titers of antibodies to SARS-CoV-2 spike genes compared to the men. And interestingly, when she began to look at multiple different cytokines, including IL-6, IL-8, and IL-18, what she found really was that men tend to make this higher pro-inflammatory response, particularly driven by higher levels of IL-18. They really distinguished the men from the women, despite the fact that they had equivalent levels of virus in the upper respiratory tract. And so what this told us is that really these cytokine profiles are popping up very early and discriminating individuals who tend to have different clinical trajectories. Now, this observation that there are these cytokines that are involved in driving inflammation and potential cellular recruitment led to this concept that potentially blocking individual cytokines, particularly those that we believe might be most essential for driving this pathological condition in the lungs, might be beneficial. And so this led to several trials, including a trial aimed at testing whether an anti-IL-6 antibody, otherwise known as TOCI, could potentially change disease trajectories and potentially improve clinical outcomes. Now, unfortunately, in this particular trial, what they found was that in patients that received TOCI in the blue versus those who received a placebo treatment, unfortunately had no differences in mechanical ventilation needs, had no differences in the worsening of the clinical symptoms, as well as had no differences in requirement for oxygen. So unfortunately, blocking individual points in the cascade, and particularly IL-6, which is thought to be critical for that pro-inflammatory cytokine storm response, has not panned out and shown real clinical benefit. Now, so that got us thinking, well, what is it then that is driving this cytokine storm? And can we begin to apply immunological tools to understand what's driving this phenomenon? So instead of trying to develop therapeutics that can interfere with these downstream cytokine responses that may simply be biomarkers of a particular inflammatory response, but not causing or the causative agent of driving this inflammatory problematic activity, perhaps we can find other potential mechanistic players that might be really driving this phenomenon. And so, of course, we know that the virus itself can be sensed by immune cells, including macrophages, and these viral particles through these particular pathways may lead to these cytokine storming effects that may be a consequence of or be associated with these pathological severe disease symptoms. But what we've come to appreciate from other diseases, including autoimmune diseases, other inflammatory diseases, is that the virus is rarely seen alone, and that in fact, in the context of infection, often what we have are viruses that are complexed in antibodies. These are immune complexes, and that these immune complexes can then trigger monocytes and macrophages. And it's these immune complexes, rather than the virus alone, that might be key to driving these cytokine storms and pro-inflammatory cascades. So what we began to think about is whether or not there was something about the antibodies, rather than the virus or the cytokines themselves, that might be fundamentally different, and that could be causing this difference in the cytokine response across different individual populations. So antibodies do a whole lot more than simply bind and block viruses. The dogma in the vaccinology field is that antibodies that can bind a virus and can block infection are really absolutely critical for providing protection from infection. But what we've come to appreciate over the last 20 or 30 years is that antibodies do a whole lot more than just simply bind and block pathogens. In fact, antibodies can recognize pathogens and opsonize pathogens or recognize infected cells. And once these antibodies bind, these antibodies act as molecular beacons that can draw in immune cells close enough to these antibody opsonized targets and begin to deploy different forms of inflammatory or anti-pathogen activities, including the secretion of cytokines, pathogen or immune complex uptake, cytotoxicity, release of different and diverse inflammatory granules from granulocytes, as well as the activation of dendritic cells that are involved, again, in driving more effective T cell or cytotoxic T cell responses. And so here's where we began to think, well, maybe it's the antibody inflammatory response that's somehow derailing that early interaction between the virus and the host. And maybe it's an immune complex-based disease that might be contributing to these differences in these pathological manifestations that we're seeing across COVID-19 infected individuals. So to begin to test this hypothesis, we applied a tool that we have developed in the laboratory called system serology. System serology is essentially a highly parallelized platform of assays that essentially interrogate the biophysical features of our pathogen-specific antibodies, as well as the functional characteristics of our pathogen-specific antibodies. And these can be characterized from almost any fluid from patient populations. And so what we do is we take plasma, and on the biophysical level, we can capture the overall level of different isotypes or subclasses of antibodies to up to 500 different antigens or epitopes or viral variants of our target pathogen of interest. We can also purify these antigen-specific antibodies and ask if they bind to Fc receptors with different affinities. And we can also purify the antigen-specific antibodies, and we can ask if they are glycosylated in any particularly different way, because we know that this sugar is absolutely critical for controlling the affinity for antibodies for the receptors that drive inflammatory cues on immune cells. In parallel, we ask if our pathogen-specific antibodies can fix complement, activate neutrophils, macrophages, monocytes, NK cells, eosinophils, dendritic cells. We ask if they drive apoptosis, if they can interact with other immune cells like T cells and B cells, if they can bind and activate non-immune cells, including epithelial and endothelial cells, as well as we can ask if these antibodies can drive enhancement or uptake of the virus in different kinds of immune cell types. Here we capture many different types of data points that we can then integrate in a very similar way to how we use data for transcriptomic analyses. And we use this data then to find patterns using machine learning tools that can explain why one population might have different antibodies that might confer protection or potentially drive more of an immunopathological profile. And just to give you an example here of an influenza-specific response captured across 120 different individuals. Each row here is a different individual. Each column is a different data point that we captured. The only point I want to make here is that you can see that there are clearly differences where there's one group of individuals here on the top that make hotter antibody responses, so more antibodies that in fact can bind to particular Fc receptors with a higher capacity than the individuals down here that make colder immune responses. So you can start to begin to see patterns in the data. And I want to use this tool now to begin to understand whether or not antibodies can form immune complexes that can then contribute to this divergence or difference in immune complex in COVID-19 infection. So the story I'm going to tell you about today of how we apply this technology is really to begin to think about populations where there are differences in clinical manifestation. And we became particularly interested in children and adults that develop mild disease. And so what has become clear over the pandemic is that children, although they can be infected with SARS-CoV-2 and infections are quite prevalent, these children tend to require hospital support much more infrequently than, for example, older adults. So children really do seem to have limited evidence of disease. And so the question is, why don't children develop disease? And can we begin to learn from children and adults that have mild disease to begin to understand what it is that's different in adults with severe disease that can explain what might be driving these inflammatory cascades that might cause pathology. So we began to compare adults with either mild disease, severe disease, or children. And we began to look at overall differences in their SARS-CoV-2 specific antibody profiles. So we're looking here at the spike specific response, so the dominant antigen on the surface of the virus. And we looked at overall levels of IgM antibodies, our earliest antibodies involved in the response to viruses. And hopefully what you can see here is that the IgM levels, or IgM titers, were highest in adults with severe disease. And interestingly, there were comparable levels of IgMs in children that tend to have very mild disease courses, as well as in mild adults, really almost indistinguishable across these two populations. We also looked at IgG1 titers. Here again, you can see here that the severely infected adults have the highest IgG1 titers and no difference in the ability of the children or the mild adults to mount these IgG1 responses. They're almost identical, so really no differences in IgM and IgGs. But we also began to look at the ability of antibodies to SARS-CoV-2 to recruit complement deposition, so antibody-dependent complement deposition, antibody-dependent neutrophil phagocytosis, or antibody-dependent monocyte cellular phagocytosis. And again, the only point I want to make here is here are these immune complex-based assays where we ask if we can activate different immune cascades. And you can see here that there really are higher levels of these functional antibodies in the adults with severe disease, and really almost identical levels of these antibody inflammatory responses present in the plasma of children that develop mild disease or adults who have mild disease, really almost identical across all functional assays that we looked at. And if we look at the response as a composite, really just comparing how much of an immune response, different isotype subclasses and functions we see in these different groups, hopefully what you can see here is that the adults with severe COVID disease have really robust humoral immune responses to the viral antigens, whether it's the receptor binding domain, the spike antigen, or the nucleocapsid antigen. And interestingly, children that develop mild disease and adults that develop mild disease have almost indistinguishable lower antibody responses, although present. They have lower responses, not as pro-inflammatory as what we see in adult severe infection. So to try to gain a little bit of a deeper sense if everything is lower or are there particular differences in the immune responses that we see in either adults or children with mild disease from the adults with severe disease, to really get at a better understanding of what might be driving differences in inflammatory responses driven by SARS-CoV-2 antibodies or immune complexes, we began to take all the data that we collected, as we collect lots of different parameters of the humoral immune response. We began to ask if there are any multivariate profile differences across our patient populations. So initially, we looked to see whether or not we could distinguish antibody profiles across adults with mild disease in the pink versus children that have mild disease. And here in this multivariate profile, if the dots are close together, they are more similar. If they are further apart, they are more dissimilar. And hopefully what you can see here is both the pinks and the light blues are mixing together, really suggesting that these two groups, whether you're a kid or you're an adult with mild disease, you really have indistinguishable antibody responses to SARS-CoV-2. So really they're generating similar immune profiles. On the other hand, if you compare the adults with severe disease on the right side in the dark blue versus the children who have mild disease in the light blue, you can see almost a perfect split in these two antibody profiles, suggesting that there is something fundamentally different in these antibody profiles. And so the question was, is qualitatively, what is most different? And is that feature in these responses potentially contributing in some way to some sort of inflammatory consequences that can drive cytokine storm? So to try to get at that, what we began to use is some machine learning tools that could take all this data and begin to ask if there are some fundamental differences in the humoral immune responses across kids with mild disease and adults with severe disease that could tell us about the triggers in the antibody response to these inflammatory profiles. So what you can see here is using this machine learning tool, using all this antibody data, we could almost completely split out individuals, the adults with severe disease in the blue versus the kids that have mild disease. So just with antibody data alone, we can already resolve who is who almost perfectly. Now, interestingly, the model picked just 5 features of the antibody profile that really help to explain why adults with severe disease are most different from kids. All these features are listed on the right side, and interestingly, these features marked very specific immunological phenomenon, including higher levels of IgA responses. This is our mucosal antibody isotype involved in responses to diseases in the lung or to any kind of inflammatory response in the lung. Higher levels of nucleic acid-specific IgAs and spike-specific IgAs linked to higher levels of phagocytosis either by monocytes or neutrophils to the spike neutrophil. So interestingly, what we began to see is what made these kids so different from severe adults is that the severe adults, all these were enriched in severe adults, made high levels of IgA and phagocytic immune complex activating antibody responses. So to begin to ask the question whether it was these IgAs that drive phagocytosis that were key to driving differences in some sort of inflammatory response, what we began to do was to take the plasma from these severely infected adults or mild adults or children and began to deplete their IgAs and ask the question, does this change the phagocytic activity of the immune sera? And hopefully what you can see here is that when you take away the IgAs from the severely infected individuals, on the large part, there's a small but significant reduction in the overall level of phagocytosis mediated by the sera when you just remove the IgA. This was not observed in the mildly infected adults or the children because they had low levels of IgAs. Interestingly, if you deplete both IgG and IgA, so you really deplete out both of these types of antibodies, you get a super significant decline in phagocytic activity, really suggesting that the IgA might be driving some of this phagocytic activity. So these functions are linked. But interestingly, that these IgAs might be working with other antibody subclasses or isotypes to drive their overall inflammatory activity. Now, more importantly, when we depleted the IgAs, the IgGs or the IgAs, we began to look to see what are the consequences on immune cells for different types of molecules, inflammatory molecules that are produced in the presence of these antibody sera. So if you, for example, take naive, non-depleted plasma and you ask whether you deplete IgGs, if you change the overall degranulation by neutrophils, what you can see here is that IgG depletion reduced the primary degranulation or release of MPO, which is a myeloperoxidase. And IgA was also able to do this at equivalent levels, even though IgA seemed to induce a weaker phagocytic consequence on neutrophils. But IgA was as potent in shifting the overall degranulation of neutrophils. Interestingly, IgA also depletion led to equivalent levels of secondary degranulation by granulocytes, including reduction of the release of lactoferrin, and was more significantly capable at reducing the overall level of enzyme release from granulocytes that might be key to destruction within the lung tissue. And probably most profound and interesting was that the removal of IgA led to much more significant attenuation of IL-1 beta secretion, IL-6 secretion, as well as similar levels of IL-8 diminution following immune complex activation, suggesting that IgA itself, even though it is not as present at as high levels in the blood as IgG, IgA is having a profound impact on shifting the overall cytokine cascade released by immune complexes in the presence of immune cells. Now, when we take all this data and we aggregate it together, hopefully what you can see here is really that the depletion of IgA really shifts the overall antibody profile in this principal component analysis, where the cytokines that are produced normally by the undepleted fraction of the plasma is really very different than when you deplete IgGs versus when you deplete IgAs. And here, looking at the loadings plot and to look to see what is most different, we can see here that IgA down here in the bottom, this is a mirror image, really leads to the most dramatic diminution of all cytokines that are characterized as being critical for that early cytokine cascade in COVID-19 disease. So hopefully what I've convinced you of today is that while we see these cytokine storms that lead to these differences in disease trajectory, what's fascinating is that one of the root causes of this difference in this cytokine inflammatory cascade may be the flavors of antibodies that we induce early on in the response to the virus. And individuals that make higher levels of IgAs might be driving enhanced disease by driving immune complex-based release of cytokines that may contribute to these pathological symptoms that we see in individuals that progress towards more severe disease. And this really, draws our attention to the sort of double-edged sword activity of antibodies, where on one side, antibodies can be incredibly protective and they can help to clear viruses and improve disease outcome. But in other situations, IgAs might activate immune cells to lead to degranulation, cytokine secretion, as well as nonspecific cytotoxicity that can lead to enhanced disease. So with that, I just want to thank the folks who did the work. This work was done by 4 very talented students and postbacks in the laboratory, coupled to a postdoctoral fellow and a graduate student in computational biology. This work would not be possible without Doug Laufenberger, my partner in crime on the computational side from MIT. Collaborators that provided proteins, our clinical colleagues, Ed Ryan, Rochelle Charles, Lael Yonkers, that helped us with samples, and Dan Baruch for his help with neutralizing antibody assays, and to our funders. Thank you for your attention.
Galit, thank you so much. That was just a beautiful, superb talk with lots of fascinating information, a lot that I hope we can get back to during our panel discussion later on. It's now my pleasure to introduce another colleague of mine, also a co-chair of the Harvard University Center for AIDS Research, Dr. Raj Gandhi. Raj is a professor of medicine and an infectious disease consultant at Massachusetts General Hospital. We've collaborated for many years in work through the AIDS Clinical Trials Group, where Raj has had a major leadership role, especially in work trying to understand the viral reservoir and approaches to HIV eradication. And like everybody else, has now shifted some of his focus at least towards COVID-19 and has been helping to direct some of the therapeutics research on COVID-19 that's happening at Mass General. Today, Raj is going to talk to us about the use of corticosteroids for managing COVID-19. Raj?
So it's a pleasure to be here today. I want to thank the organizers for inviting me to speak. I'm going to be talking about the topic of corticosteroids for treatment of COVID-19. So before we delve into the corticosteroid aspect of the talk, I would just want to set the stage by sketching out what I consider the 3 dimensions of approach to treating COVID-19. The first is the clinical manifestations themselves. We know that COVID-19 is largely a respiratory illness, but there may be multi-system involvement, and that in part might be driven by something called thromboinflammation, which we'll touch on. The second dimension of treating COVID-19 is the stage and severity of disease. The interventions are likely to differ between early and late infection, and certainly differ between mild, moderate, severe, and critical illness. And then and only then is the particular intervention considered. Is it an antiviral? Is it an immunomodulator? Is it a combination of the two? And of course, treatment of complications such as anticoagulation and ventilatory support. So here's a brief sketch of the multifaceted nature of COVID-19. As I mentioned, it's largely a respiratory illness, but almost every organ system can be involved. The central nervous system in the form of strokes, cardiovascular complications such as myocardial infarction, renal failure, liver function test abnormalities, a number of cutaneous manifestations have been evident, and then systemic manifestations can include cytopenias, but also coagulopathies. Now, very early in the course of the description of COVID-19, these data out of China have really been influential. What this graph shows on your right is in the red are non-survivors of COVID-19, and then the blue line is survivors of COVID-19, and this is a graph as a function of time. And you can see that the non-survivors had much higher levels of coagulation markers such as D-dimer, and also much higher levels of inflammatory markers such as interleukin-6. So this has led to the proposal that the inflammatory response itself may lead to endothelial injury and coagulopathy, particularly in severe COVID-19. And then the ensuing complications may include pulmonary emboli, myocardial infarction, and disseminated intravascular coagulation. So I say this as a stage to what I think can be considered a treatment paradigm across the COVID-19 spectrum. So starting with asymptomatic and pre-symptomatic disease, and we'll go through a few definitions. Asymptomatic and pre-symptomatic disease is people who have a positive test but have no symptoms at all. Mild COVID-19 is typically symptoms of or signs of fever, cough, taste, smell disturbances, but in this stage, there's typically no dyspnea or shortness of breath. Now, moderate disease is when there's a preserved oxygen saturation, but evidence of lower respiratory tract disease, either clinical evidence of lower respiratory tract disease or radiographic evidence. Severe illness, as defined by the WHO, is a decreased oxygen saturation, usually less considered to be severe when less than 94%, or an elevated respiratory rate or lung infiltrates that are very extensive. And then, of course, critical illness is respiratory failure, shock, multi-organ dysfunction, or multi-organ failure. The reason why I sketch out the severity is it's thought in terms of disease pathogenesis that viral replication is driving the early stages of COVID-19, the mild symptoms and into the moderate disease stage, but that during severe illness and or critical illness, a hyperinflammatory response is particularly evident. And this is important because it leads to the proposals that antivirals are likely to work best earlier in the course of disease. And I count antibody therapies, the monoclonal antibodies within the category of antivirals. And it's the anti-inflammatories that we're talking about in this session that are most likely to work during severe or critical illness. And that's, of course, where corticosteroids fit in. It's really during the severe and critical illness, as we'll sketch out when we talk about the clinical trials results. But again, this is a paradigm, I think, under which a lot of us are working on treatment of COVID-19. So early in the COVID-19 pandemic, there was an influential article published by John Moore and Carl June that proposed that perhaps severe COVID-19, people who are requiring oxygen or have critical illness, may be in part driven by a cytokine release syndrome. And just in the last weeks, they've updated this with a nice review article in the New England Journal of Medicine, where they really delved into the nature of the cytokine storm syndrome. And now Dr. Alter has discussed this in detail during the session. So I'll much more briefly touch on cytokine storm as a prelude to talking about corticosteroids. So there's a number of potential triggers for cytokine storm. Many of them are iatrogenic causes, such as CAR T-cell therapy, of course, where it was very well described, also cancer itself. But then a number of pathogens have been proposed to trigger a cytokine storm, and amongst them is the SARS-CoV-2 virus. Now, when cytokine storm is set up, it can cause an immune hyperactivation syndrome. And on this next slide, you can see that this cytokine storm is really manifest with a variety of different chemokines and cytokines that are dysregulated, that I'm sure Dr. Alter will have discussed. But what can happen is that there can be prolonged activation of signaling pathways. And I use this as a stage to now delve into the mechanism of corticosteroids, which really work on some of these signaling pathways, such as NF-kappa B. So here's a nice schematic of what the authors call a molecular architecture of how glucocorticoids work, just to take us back to the fundamentals of how steroids are really acting. And I've really drawn out from this molecular architecture a couple of the high points. One is that after the glucocorticoid binds to the glucocorticoid receptor, it blocks the transcription of a number of inflammatory proteins, for example, by affecting the transcription factor NF-kappa B. Conversely, glucocorticoids also induce expression of anti-inflammatory proteins such as I-kappa B and MAP kinase phosphatase. So there can be a number of molecular events that follow the binding of the glucocorticoid to the glucocorticoid receptor that have an anti-inflammatory effect. Now, there are a number of pleiotropic effects of glucocorticoids that even extend beyond the cytokines. So, of course, On cytokines themselves, glucocorticoids can reduce levels of interleukin-1, the original cytokine, the so-called endogenous pyrogen, but it can also reduce levels of multiple other cytokines, including TNF-alpha, GM-CSF, and a number of other interleukins. Now, the physiologic effect of this dampening of cytokines is to decrease inflammation that are caused by those cytokines. In addition to this physiologic effect, we know that glucocorticoids can also decrease nitric oxide. Glucocorticoids have an effect on phospholipase A2, on cyclooxygenase, and even on annexin. And the end result of these effects is that the glucocorticoids decrease prostaglandins and decrease leukotrienes. Corticosteroids can also affect adhesion molecules, and this is probably the basis of the well-known effect of corticosteroids on demargination of leukocytes. So by affecting adhesion molecules, there's reduced emigration of leukocytes from vessels and a resulting increase in the white count. And then there can be an effect on increasing endonucleases, which induces apoptosis in lymphocytes and in eosinophils. We're all aware of the fact that when you use glucocorticoids pharmacologically, the eosinophil count typically goes to 0, and lymphocyte numbers also go down. So this is the stage on which some considerations came about in the early days of the COVID-19 pandemic as to whether steroids should be used. And there were a number of pros and cons in terms of whether steroids should or should not be used in COVID-19. So some reasons that were postulated for the use of steroids included the fact that in other inflammatory infections, such as pneumocystis pneumonia, steroids had been shown years ago, decades ago, to reduce mortality. There's been an ongoing vigorous debate around the use of steroids in acute respiratory distress syndrome, or ARDS. But in a relatively recent meta-analysis of randomized trials in patients with ARDS, steroids reduced all-cause mortality and duration in mechanical ventilation. Although it is important to say that a number of critical care experts are still unsure of the role of steroids in ARDS, and there's still a debate on that front. There were, though, several reasons not to use steroids as well. So in other lethal human coronaviruses, in MERS and in SARS, steroids have been associated with delayed virus clearance. That is, the antiviral response itself, by being tamped down by steroids, resulted in delays in virus clearance. And in severe pneumonia caused by influenza, there are data suggesting that steroids appear to worsen clinical outcomes. So there was real equipoise, as I think you can see in this balance sheet here, in terms of whether steroids should or should not be used in COVID-19. And actually a number of guidelines panels, including the Infectious Diseases Society of America, of which I'm a member of their guidelines panels, were originally very cautious about the use of steroids prior to the results of the trial that I'll show you next. So the trial that really has influenced our thinking more than any other clinical trial is the recovery study, and the particular part of the recovery study that focused on dexamethasone, an important corticosteroid. So as a reminder, this particular trial, which was done in the UK, is an open label randomized study among patients hospitalized with COVID-19. So these are patients who are ill enough to be in the hospital. This does not pertain to outpatients with COVID-19. In this part of the recovery trial, patients were randomized to receive either dexamethasone, 6 milligrams per day for up to 10 days, or until hospital discharge, if hospital discharge was prior to 10 days. And a little over 2,100 people were in the dexamethasone arm. They were then compared to usual care, that is non-dexamethasone containing usual care. And here the sample size was correspondingly large. It was a little over 4,300 people were in the usual care arm. Now let's just say a word about who was in recovery. The mean age of participants in recovery was in the mid-60s. The majority were men, 36% female. Major coexisting illnesses were present in a little over half. About 1 in 6 were severely ill enough to require mechanical ventilation or ECMO. About 60% were receiving oxygen, although the amount of oxygen, as I'll touch on a bit later, was not specified. So it's not clear if the people on oxygen were requiring low amounts of oxygen or requiring non-invasive ventilation. And a little under a quarter were in the hospital, but were not receiving either mechanical ventilation, ECMO, or supplemental oxygen. So what were the results of the recovery trial? So let's go through this in some detail because I think this is important. So among all participants in the dexamethasone group, the mortality here was a little under 23%. And this was statistically significantly lower than the mortality in the usual care group, which was 25.7%. So when they looked at the rate ratio for mortality, it was 0.83. And so you can translate that as a 17% reduction in mortality. Now, what was important in the recovery trial is that the greatest benefit was in those individuals who were most severely ill. So when you look at the people, the subgroup that were on mechanical ventilation or ECMO, here the mortality in the dexamethasone group was 29%, and in the usual care group was substantially higher, it was 41%. So the rate ratio for mortality for those who were critically ill on mechanical ventilation or ECMO, there was a 36% reduction in mortality, a rate ratio of 0.64. In people who were requiring oxygen but were not severely ill enough to require mechanical ventilation or ECMO, the mortality in the dexamethasone group was a little over 23%, and in the usual care group was 26%. So the rate ratio for mortality was 0.82, or an 18% reduction. And then here is an important point that bears emphasizing, which is in the no oxygen group. They're in the hospital, but they're not requiring oxygen. Here, the mortality was actually higher in those people who received dexamethasone, 17.8% versus usual care, 14%, so numerically higher. The rate ratio was 1.19. And so that's an important a lesson of the recovery trial. An important secondary endpoint was progression to mechanical ventilation if one was not on mechanical ventilation to begin with. And this also showed a lower rate ratio for progression to mechanical ventilation in the dexamethasone group, a rate ratio of 0.77. So let me emphasize again, among the oxygen group alone, not mechanically ventilated, the amount of oxygen was not specified. And certainly in the panel discussion, this would be a point to come back to in terms of where dexamethasone has its greatest effect. But it is safe to say that the conclusion of the recovery trial is that dexamethasone is associated with decreased mortality among those on supplemental oxygen or mechanical ventilation, with the greatest benefit in those on mechanical ventilation or ECMO. And this is the corollary. Importantly, there was no benefit and the potential for harm in those not requiring oxygen. And one point to stress to our colleagues who are mostly doing outpatient COVID care is there is not a role for dexamethasone in patients who are not ill enough to be in the hospital and requiring oxygen therapy. And when we get to how this has influenced the guidelines, we'll emphasize that again. Let me examine with you one important subgroup in the recovery trial. And this particular subgroup is the subgroup of people in terms of the days since symptom onset. And what you can see here is that the greatest benefit of dexamethasone was in those individuals who had more than 7 days since their COVID-19 symptom onset. And this, I think, fits nicely with that initial treatment paradigm, with that as individuals get later in the course of the disease, further from the time of symptom onset, that's when that hyperinflammatory syndrome really kicks in with a vengeance. And we know that most people who have had declines in oxygenation do so about a week or so after symptom onset. And that's probably when the anti-inflammatory effects of dexamethasone are going to be most pronounced and most clinically beneficial. So the recovery trial by far is the single most important trial when it comes to dexamethasone and COVID-19, but it's not the only study that provides support. And I'll go through just a couple of other studies that provide additional evidence. And these studies are in critically ill patients. So recovery included a gamut of disease, but these studies that I'll show you now are in those individuals who are most severely ill. So the first, and all of these were published not long ago in an issue of JAMA. So the first of these comes from France, the Cape COVID study, just under 150 people with COVID-19 in the intensive care unit. This study used an alternative corticosteroid. They used hydrocortisone. The 21-day mortality was just under 15% in the hydrocortisone group, and it was over 27% in the placebo group. There was a trend towards decreased mortality. An international study called REMAP-CAP was done in over 600 patients in the intensive care unit again. Here, the main finding was that hydrocortisone is likely to be superior to no steroids in terms of organ support-free days. And then the CODEX study from Brazil, just under 300 people, again in the intensive care unit. And here dexamethasone was associated with an increase in ventilator-free days. So the WHO did a meta-analysis of 7 randomized trials of corticosteroids versus placebo in critically ill COVID-19 individuals. They had over 1,700 people in this meta-analysis. Importantly, though, the single biggest study that contributed to this meta-analysis was the recovery trial that we've already gone over. 59% of individuals, participants in the meta-analysis were from recovery. But, and this is in the graphic on the right, the 28-day mortality was lower in this meta-analysis among patients who received corticosteroids, with a summary odds ratio of 0.66, which is very similar to the result in critically ill patients in the recovery trial. So the conclusion from this meta-analysis is that systemic corticosteroids is associated with lower 28-day all-cause mortality in critically ill COVID-19 patients. So let me synthesize some of this information and bring it back to a couple of the treatment guidelines panels here in the United States. I'm a member of both of these panels, and I can go through some of the recommendations from the Infectious Diseases Society of America, as well as the National Institutes of Health COVID-19 treatment guidelines panels. And these guidelines really follow the data that you've seen presented so far. So these are the IDSA guidelines. They have a strong recommendation for the use of dexamethasone among hospitalized critically ill patients. For patients who have severe but not critical COVID-19, based on the recovery data, the IDSA suggests the use of dexamethasone. And finally, and this is important, among hospitalized patients who do not have severe COVID-19, that is, who do not have hypoxemia requiring supplemental oxygen, the IDSA suggests against the use of glucocorticoids. The NIH treatment guidelines panel has a very similar perspective. In those who are hospitalized with COVID-19 but are not requiring supplemental oxygen, dexamethasone should not be used, and that's a strong recommendation. Among those who are hospitalized and require supplemental oxygen, but are not on mechanical ventilation, but are not on high flow or non-invasive ventilation, several options are outlined by the NIH. Remdesivir, for example, among patients who require minimal supplemental oxygen. The NIH suggests the use of dexamethasone plus remdesivir, for example, in those patients who require increasing amounts of supplemental oxygen. Although I hasten to add that this is not based on clinical trials data. There are not adequate clinical trials data with the combination of dexamethasone plus remdesivir, at least not randomized data. And so this recommendation is based on expert opinion. Dexamethasone also is an option, particularly when combination therapy with remdesivir cannot be used or when remdesivir is not available. A continuation of the NIH treatment guidelines panel for those patients who are hospitalized requiring oxygen delivery through a high flow device or non-invasive ventilation. Here the options are considered to be dexamethasone alone or the combination of dexamethasone plus remdesivir, again with the stipulation that we don't have clinical trials data on combination therapy, so this is expert opinion. And then finally, among those patients who are hospitalized requiring mechanical ventilation, the strongest recommendation here is for dexamethasone, although there are some experts who will give the combination of dexamethasone plus remdesivir in those individuals who've been recently intubated. I'm happy to discuss that again in the panel discussion. So a few other considerations for corticosteroids for COVID-19. A reminder that dexamethasone is a moderate cytochrome P450 3A4 inducer, and it may actually reduce concentration and efficacy of concomitant medications that are CYP3A4 substrates. The co-administration of remdesivir and dexamethasone has not been formally studied, but a clinically significant interaction is not predicted. In terms of duration of dexamethasone dosing, it should be continued for up to 10 days or until hospital discharge, whichever comes first. And if dexamethasone is not available due to a shortage or some other reason, equivalent doses of other corticosteroids may be used, such as prednisone at a dose of 40 milligrams a day, methylprednisolone, a total dose of 32 milligrams a day, or hydrocortisone at a total dose of 160 milligrams per day. Now, one reminder for all of us in the infectious diseases world, we know that corticosteroids can reactivate a number of latent infections, usually with prolonged use. So prolonged systemic corticosteroids may increase the risk of hepatitis B reactivation, herpes virus infection reactivation, strongyloidiasis, and tuberculosis. And in particular, patients who are from high-risk regions of the world for strongyloidiasis, for example, patients from tropical or subtropical regions, warm temperate regions, or individuals who are involved in agricultural activities, should be appropriately screened, and in many instances, we will empirically treat to prevent strongyloides hyperinfection syndrome, which can be devastating. So let me begin to close out the talk with just a few thoughts about the future. And one is the possibility in the future, and this is not ready for prime time, we don't have adequate data on this topic yet, but the possibility of biomarker-guided therapy. The recovery trial was a clinical endpoints trial with not a lot of biomarker, in fact, really without biomarkers built in to guide therapy. But an intriguing study that was actually presented and published even prior to recovery came out of New York City, where they looked at over 1,800 people hospitalized with COVID-19, of whom 140 received early glucocorticoids, that is glucocorticoids within 48 hours of an admission. And what they found is that the glucocorticoid treatment had its best effect, had its greatest effect in those people who had a CRP, a C-reactive protein of over 20 milligrams per deciliter. In that group in particular, there was a substantial decrease in mortality or mechanical ventilation. And so it brings up the idea of biomarker-guided therapy, although I do not think this trial establishes that role. It just brings up the possibility and something for the future that should be studied. So let's return to our treatment paradigm. And as you can see, again, the severity of disease is substantially different depending on where one is in the COVID-19 spectrum. I think dexamethasone fits securely in the severe to critical illness category in terms of where it's going to have and where it does have its greatest benefit. So here are my final thoughts. In patients hospitalized with COVID-19 who require oxygen, dexamethasone reduces mortality. And really, it's the only drug to date that's been proven to reduce mortality, and that's an important point to remember. In terms of where we go in the future, a number of unanswered questions still, and people are debating. I think we really need to know more about these possibilities. Should steroid initiation, dosing, and even duration be guided by clinical response or by biomarkers? I mentioned the possibility of CRP, but there may be others in the future. And again, more clinical data is needed to inform this, to answer this question. Should corticosteroids be tapered rather than stopped abruptly? Right now, in typical clinical practice, we will stop dexamethasone without a taper. Is that the right thing to do? Again, a topic that should be studied. What is the clinical impact of combining steroids, a potent anti-inflammatory, with other agents? And in particular, what is the impact of combining steroids with antivirals? At the outset of this talk, we talked about the balance between viral replication and the immune response. Should steroids be combined with antivirals? We need to do trials to find out. And are there other combinations of immunomodulators? In addition to the kind of very broad spectrum potent steroids, are there other immunomodulators that should be combined? And then finally, can more targeted immunomodulatory agents be developed to treat COVID-19? We talked about the pleiotropic effects of corticosteroids. Are there targeted, customized ways to really intervene with targeted therapy? And I think this would be a great topic for the panel discussion and a great topic to explore in future clinical trials. So with that, I will stop. Thank you for your attention. Pleasure to be here and looking forward to the panel discussion.
Thanks, Raj, for that great review of all of the clinical data and for placing this in such nice context and giving clear guidance on the use of corticosteroids. I'd like to remind everybody that you can submit questions through the live Q&A widget, and we'll get to as many of those questions as we can during the roundtable. It's now a great pleasure to introduce the third speaker for this afternoon's for session 2, the first part of this afternoon's workshop, and that is Professor Karine Lacombe, who is the head of infectious diseases at the Department of, head of the infectious disease department in Saint-Antoine Hospital in Paris. Professor Lacombe, in addition to being a physician, has a PhD in epidemiology on HIV and hepatitis co-infection, where she has done a lot of important work. She is a member of the editorial boards of numerous high-impact journals and has, like everybody else, have come to play a significant role in providing and organizing care for people with COVID-19 in Paris, and particularly as France went through its initial and now its resurgent waves of COVID-19. In addition, she gave a really superb talk at the Glasgow conference on antiretroviral therapy on COVID-19, and we're pleased to have her speaking to us today. Professor Lacombe is going to help us make sense of the vast array of anti-inflammatory therapies in addition to corticosteroids that have been tried with rather mixed results. And so here to take us through all of that, Professor Lacombe.
Hello, everybody. I'm very happy to be here today to share with you some data regarding COVID-19 and the anti-inflammatory therapy. I'm Karine Lacombe, professor of medicine, specialist in infectious disease, and I work in Paris, Saint-Antoine Hospital, Sorbonne University. First of all, you can see here my declaration of interest updated on the 15th of December 2020. And just before I start with the treatment, I'd like to set up the same by reminding you about the natural history of COVID-19. So you see here that COVID-19 is modeled on 3 stages. The first stage, which is early infection, which corresponds to the viral response phase, where obviously anti-inflammatory drugs are not indicated, and phase 2 and 3, which are pulmonary phase, where the heart inflammatory response phase starts, and then stage 3, which is in hyperinflammation phase. And anti-inflammatory drugs are really targeting those 2 phases here. You see on this very basic picture a summary of all the drugs which have been developed and repurposed to target the anti-inflammatory phase of the COVID-19 disease. And they really try to interfere with an inflammatory pathway which is triggered during the cytokine storm that we see in severe COVID-19 forms of the disease. And I will really focus on 3 kinds of inflammatory drugs here, the interleukin-6 inhibitors, interleukin-1 inhibitors, and JAK inhibitors, which doesn't mean that the others could not be evaluated, but right now we do not have sufficient data supporting the use in routine care. And you will even see that for the anti-inflammatory drug that I will share with you, it's not still completely indicated in the current recommendations worldwide. So first of all, let's see the interleukin-6 inhibitors, and I would like to remind you of the brief mechanism of action of those inhibitors. So you see on the left side of the slide how the soluble interleukin-6 receptor can trigger the signal transduction, which leads to the inflammatory storm. And when you look at the right picture, that's where the anti-interleukin 6 receptor that inhibits the mechanism of action of interleukin 6 that blocks the signal transduction and calm in the inflammatory storm. So the most used drugs of this class is tocilizumab. Tocilizumab has been extensively used in internal medicine for years and years, and it has been repurposed as a drug that targets the interleukin 6 receptor and block some of the cytokine storm. So a lot of clinical trials and retrospective cohorts have been published, and I've decided to share with you the results reported in this meta-analysis because that's the only one which reports the results of the Covacta, Impacta, and Corimino, Toci, and Back-Bay, and OCT, TCZ, COSI-19 clinical trials. 5 clinical trials to date have been indeed published. And you see here that the effect of tocilizumab of 28-30-day mortality in those 5 randomized trials is not proved to be significant. So no significance of effect on the mortality in those randomized trials. But there was no difference in risk of infections and adverse events when using the tocilizumab. That was one of the problems that we wanted to eliminate when using the tocilizumab. But regarding another effect of tocilizumab, this one on mechanical ventilation in randomized trial, you see that this effect is positive in favor of tocilizumab when you look at the effect. So there is a decrease in about 30% of the risk of mechanical ventilation in patients treated with tocilizumab compared with placebo, which is quite a good result. And when you look at the composite outcome, ventilation, mechanical ventilation and death, this is here again positive, and this is clearly driven by the decrease of risk of mechanical ventilation. So a pretty positive result of tocilizumab reported in clinical trials regarding the risk of clinical progression. And here you've got the effect of tocilizumab on short-term mortality in that time moderately biased cohort, retrospective cohorts, and you see that this effect, this positive effect on short-term mortality has been reported in moderate to severe patients, severe critical, and critical, not really in critical and severe critical, but really mostly in moderate, severe, and severe. This is a borderline effect, but also marked in severe critical and critical. So I will give you some of the conclusion regarding the tocilizumab use a little bit later on. So now if we switch to the JAK inhibitors, you've got here the brief mechanism of JAK inhibitors. You see that during the hyperinflammatory stage, there is an elevation in blood of a large panel of cytokines, including interleukin 1, interleukin 2, etc. And those cytokines activate the inflammatory stage through JAK1 or 2 receptors. And when you inhibit those receptors, there is a decrease in the inflammatory stage. So the first JAK inhibitor that has been a little bit more than others studied in the COVID-19 disease is baricitinib. And the fact that baricitinib has gone to phase 3 trial comes from this observational study assessing baricitinib 4 milligrams BID for 2 days, followed by a QD dosage for 7 days. versus no baricitinib in patients hospitalized with COVID-19 pneumonia. And you see here that the effect of baricitinib was quite marked on death, but not an ARDS or median duration of hospitalization. So you see here the effect of on the decrease of some chemokines like interleukin 1b, interleukin 6, TNF alpha, but no effect on interleukin 8. So that was quite encouraging. That's why trial has been designed evaluating baricitinib and remdesivir. That was a phase 3 trial. Remdesivir has been used as a standard of care because this trial has been designed just after the results from the first phase 3 remdesivir trials have been released. And at that time, remdesivir looked like could be the new standard of care. So you see here this study that has been very recently published in the New England Journal of Medicine. That was a multi-center, adaptive, randomized, double-blind, placebo-controlled phase 3 trial, including more than 1,000 patients with the confirmed SARS-CoV-2 infections and the moderately severe patients randomized in 2 groups, baricitinib plus remdesivir or placebo plus remdesivir. The primary endpoint was time to recovery by day 29. And you see here that overall, there was a positive effect of baricitinib plus remdesivir doing better than placebo plus remdesivir. If we look in detail the results, you see that this positive result is mainly driven by patients treated in North America, but not in Europe and Asia. Here again, if you look at the age, it's been driven, the positive result is driven by the group of patients from 40 to less than 65 years old. Again here, mainly men. And here you see that it has been mainly seen in patients with a severe form of the disease. And here again, you see that in the ordinal score at baseline, it's mostly seen in patients with a score of 6, which means patients hospitalized with need of oxygen. So we are now waiting for more data on baricitinib, and especially baricitinib alone without remdesivir, because we now know that remdesivir should be prescribed during the antiviral phase, and baricitinib is more prescribed, could have its room in patients with inflammatory stage. Now, the third group of anti-inflammatory drug that I would like to share with you is the interleukin-1 inhibitor, and mainly anakinra. So anakinra, there is no phase 3 trial published so far. So we've got data from retrospective analysis of severe forms of COVID-19. The first one has been published from patients in France, and the second one I will show you in the next slide has been published on patients in Italy. And you see here that in this retrospective analysis of a small group of patients, and the anakinra group, 52 patients, historical group, 44 patients, we see that there is a positive effect of anakinra on the probability of event-free survival, like death or invasive mechanical ventilation in ICU, or death or invasive mechanical ventilation in ICU. So anakinra in this retrospective analysis have prevented the progression to ICU, ventilation, or death. In the second study, retrospective analysis of ARDS on non-invasive ventilation patients due to COVID-19 from Italy. Here again, the survival and mechanical ventilation free survival at 21 days was better in the group treated with anakinra compared to the placebo group. So some of my take-home messages regarding the activity of those anti-inflammatory drugs. I have to say that so far, very few of those drugs have reached phase 3 trials, and no anti-inflammatory drugs have been better than corticosteroids in reducing the risk of clinical progression. Probably timing matters. It should be administered neither too early or too late. And you see that, for example, with baricitinib, the data we have is really into the middle in patients with no real viral stage anymore, but no too severe inflammatory stage. Tocilizumab has been quite extensively evaluated so far with two very big trials called Impacta and Covacta with mitigated results, and some smaller trials with better results. So there is no clear-cut answer about the room to give to tocilizumab in COVID-19 disease. It tends to have a positive effect on clinical progression in clinical randomized trial and a positive effect on mortality in retrospective cohorts. And Akinra, we are still waiting for RCTs, and it tends to be efficient in preventing clinical progression in retrospective cohorts. And baricitinib, we are also waiting for RCTs outside association of remdesivir. So I have to say that to conclude on those take-home messages, that we need to go on with the evaluation of anti-inflammatory drugs, because it's not because we are entering the vaccination era, but unfortunately patients will still get the disease and will still arrive at hospital with a severe case of COVID-19, and at that stage specifically, so far only anti-inflammatory drugs or look like they're going to work. And I would like to say thank you, merci to everybody. So you see me at the right corner, right into the management of the epidemic. And I wanted to thank you, all the colleagues I've been working with for those last 8 months at the heart of the pandemic. Thank you very much for your attention.
Well, thank you very much, Karine. That was a great talk, a very complex subject. Let me remind all of the speakers and panelists to please unmute yourselves so that when I direct questions to you, you'll be able to answer. Let me start with a couple of questions for Galit. You show how there are what we might characterize as good antibodies and bad antibodies. So if giving convalescent plasma or in selecting units of CCP for administration, should they be screened, and how would you do that?
Yeah, I mean, Dan, this is a question I think that came up multiple times in the design of the CCP trials, right? There's only so much one can do, I think, initially, in trying to make sure that what we're giving to individuals is going to have therapeutic benefit. And that included, of course, looking at titers of antibodies as well as neutralizing antibody activity. But as we dig deeper into the biology of COVID-19 disease, what we've come to realize is that there is a lot more going on in those humoral immune responses than simply, delivering neutralizing antibodies to the system. And in fact, when, these individuals have high levels of viremia, the quality of the immune complexes that we form with the delivery of this CCP can have profound inflammatory effects. And so we're now moving back and working with many of the groups that have performed some of these CCPs to characterize their donor plasma in depth, as well as how the donor plasma then alters the plasma antibodies in an individual after they have received the CCP, to begin to try to understand really if there are, underlying correlates of immunity that can help us understand really how the CCP may or may not work in some situations. The problem, of course, is that, every individual receives a different CCP donor. And so it really makes this analysis complicated, but clearly we're seeing some wins in some trials and some losses in some trials. So I think this is the way that we can unearth really where the antibodies work or don't work. And
maybe the counterpart to that question would be, what about the other half of the effector arm. How much inter-individual difference do you think either genetics or other factors play in how the cells from a particular individual are able to engage with the antibodies and mediate these responses?
Yeah, so that's one of the funnest parts. I think that, one of the biggest revelations we've made in the monoclonal therapeutics community is where we've come to appreciate the fact that, polymorphisms, particularly in Fc receptors, can have profound influences in how we respond to different kinds of monoclonal interventions. So with rituximab, as an example, individuals who have high affinity variants of Fc gamma R3A respond much more effectively to monoclonal therapeutic interventions. And so this is really where that equation becomes, both the drug as well as the host genetics that can influence the ultimate outcome. But of course, ultimately, what we want to understand is how we can develop therapeutics that will overcome any host genetic background biases. And we've been able to do that for many cancer drugs. And so the question is how can we learn from this in the context of SARS-CoV-2 so we can move beyond CCP, right, which is quite heterogeneous, towards monoclonal therapeutics like the Regeneron, Cocktail, Eli Lilly, and have them work not just in the first few days, right, following symptom onset, but have them essentially take over some of the overwhelming profiles of the infection-induced antibodies and really drive that protective immunity for longer periods of time. So I think these are, opportunities for us to learn how to design and engineer infectious disease-specific monoclonals to be highly effective throughout the disease course.
Yeah, great. No, those are terrific points. Raj, there were a number of questions that came in about some of the risk and benefit of steroids. Just two of them to think about to start off. Obviously, people with diabetes are at higher risk of progression, but corticosteroids can make diabetes worse, and we worry about opportunistic infections, as you pointed out. And there's a concern about COVID-associated aspergillus superinfection. Can you place in context for us the risk and benefit of the use of steroids?
Sure, those are appropriate and legitimate concerns, but obviously on balance, I think the benefit of dexamethasone when applied at the right time outweighs those risks. That being said, I think as clinicians, we have to be attentive to things like COVID-associated pulmonary aspergillosis. We have seen a number of particularly critically ill patients decline because of what turned out to be aspergillosis, and similarly some of the other co-infections. I would say that because of the mortality benefit, on balance, we still use this regularly. The recovery trial did not have detailed information on some of these questions that we'd like the answers to. That being said, diabetes, delirium, these in my mind are not absolute contraindications to the use of dexamethasone. I think they should be taken into account. We have long experience managing those side effects, so I would manage those side effects while still using the life-saving drug.
And then another question is about dosing, and there were a couple of questions here. I'll sort of try to cluster them here. How did people come up with 6 milligrams for dexamethasone, and should you increase the dose if people don't respond, and do you dose adjust if people have significant obesity, since we know obesity as well as a risk for progression but may alter distribution of drug?
Yeah, it's a very good question. I mean, in China, in the early days of COVID, even higher doses of equivalent steroids were being used. And there has been, as I briefly mentioned, a concern about the effect of higher doses of steroids on viral shedding in MERS and in SARS. So the dose that was decided in recovery was lower than had been commonly used prior to in the earlier studies. And I think, as the author said, they ended up choosing the right dose at the right time for the right patient. In terms of why they chose 6 milligrams as opposed to a somewhat lower dose, I think they were trying to thread that needle between the immunosuppressive effect and the anti-inflammatory effect. I would not, in general, depart from the recovery cocktail in terms of the dosing I use, just because we just don't have the appropriate data to weigh the risks and benefits of higher doses. Nor do I tend to prolong the course beyond the 10 days. And in fact, if someone recovers within fewer than 10 days, I will stop the dose of dexamethasone at the time of discharge. And that's in accordance with how they set up their trial. I am not tapering it, which is a reasonable consideration, but not something that I've adopted. again,
Yeah, that question about whether, sorry, that question about whether to, complete the 10 days or if you can just stop when someone's ready to be discharged.
a famous politician in the United States did receive more than, he continued on dexamethasone even after leaving the particular healthcare facility, but I would not advise that.
It leads to manic behavior. Karine, the study that you talked about with baricitinib and remdesivir, which was just published, is now leading to a follow-on trial, the ACT-4 study. And I guess to my surprise, that I learned today that what that trial is going to compare baricitinib with remdesivir to steroids with remdesivir. And as Raj made the point that the only therapy we know has a mortality benefit is dexamethasone, do you think people should be looking at dexamethasone plus baricitinib rather than just the comparison? We know baricitinib and remdesivir didn't have a mortality benefit, so.
No, I'm very surprised. I don't think it's a very good idea because the step that you have to go over, given the quite high efficacy of steroids, of dexamethasone, is really high. The step is really high. So adding baricitinib on top of dexamethasone compared to dexamethasone, I don't know how you think that you're going to perform better than just dexamethasone. But I have to say that I understand, the intellectual way behind that. For example, in France, we are right now evaluating tocilizumab plus dexamethasone versus dexamethasone alone. I'm not sure that it's going to prove to be better than dexamethasone. I would have, but on the other way, it's very difficult to compare baricitinib just by itself, given the kind of gold standard we have with dexamethasone right now. So that's something that should be discussed.
Right, and then other approaches to interrupting some of the inflammatory cascade have been less successful. Right? Sarilumab didn't seem to work, and canakinumab was also a negative trial. Do you think there was that much difference between toci and sarilumab?
I don't know. That's weird. I don't really know why sarilumab did not work and tocilizumab looks like it's working when you're very careful with the timing of injections. So that's an open question for me.
And then speaking of timing, one of the other things that struck me about the New England Journal paper is, overall baricitinib had a very modest effect, but when you looked at the people who entered with category 6 disease, or whatever the right term is, the people who had more than a low flow oxygen requirement but were not yet ventilated, they had a much bigger benefit. That narrow slice. So I'm curious about your thoughts there.
Well, I think it's again a matter of timing. It maybe you need the kind of level of inflammation for baricitinib to work. Maybe when the inflammation is not triggered enough, the pathway of inflammation is not triggered enough, then baricitinib is given too early. Maybe that in the cascade of inflammation, the pathway of action of baricitinib is triggered later on. So that's may explain why you have to have a certain degree of inflammatory cytokine storm for baricitinib to work.
Great. Well, we had many more questions. Unfortunately, we don't have a whole lot more time, so I'm going to take the opportunity now to thank our 3 speakers for your excellent talks. This was a really terrific session. Let me remind all of our listeners to, first of all, fill out the session survey. We'll be taking a 15-minute break and then coming back to the third and final session that will be moderated by my program co-chair, Anton Pozniak from Chelsea and Westminster Hospital. And the next session will start at 40 minutes past the hour. Thank you again to everybody.